Welcome to the Health Focus Podcast. I'm your host, Dr. Gregory Flamone, a general surgeon here at Memorial Healthcare. As always, we are coming to you from our podcast studio at the Now Building. With me today is Dr. Rami Kurdi, an orthopedic surgeon here in Owosso. Dr. Kurdi may sound familiar as he has spoken to us in the past about joint replacement and the Mako robot. Today, he's here to talk about urgent versus non-urgent orthopedic injuries. Dr. Kurdi, thank you again for joining us. It's always a pleasure to have you back. How have you been the last few weeks?
Great. Thanks for having me again.
Excellent. So let's start broad. When we're looking at orthopedic injuries, things are acute versus non-acute. What are some of the differences that patients should be aware of that can kind of lead to the urgency that they need to be, have their issues addressed?
It's an interesting question, and it really depends oftentimes on the age group. It's difficult, especially because, how many of us drive cars, and we don't really know how they're built entirely or put together. Mm-hmm. But when you do, you've got an advantage. When you hear check engine light comes on, you hear some noises in the car that sound different. When you have an acute injury versus a chronic pain, it varies. So we'll stick to adults to start. So if you're an adult and you want to look around, what's different? Always consider what is different. Why does my shoulder hurt a lot today, or my knee, or my hip? The real question we ask is, what did you do yesterday or even 2 days ago? Is the pain aggressive? There's a pain scale that we go through that you're familiar with in your department, and what type of pain is it? And what makes it better? What makes it worse? Is it aggressive? Is it stopping you from doing your normal activities? Those are common questions to ask yourself before you present. So really the biggest question is it emergent? Mm-hmm. What do I have to get to the ER for? And I think that's a good question to answer first. What do you think?
So what are those signs and symptoms? Do people need an inciting incident? Like a car accident, obviously that's going to lead you to the emergency room. But what are some things that patients should realize? Hey, I need to go to the ER. I need to go to urgent care, or maybe this can wait for my primary care doc. Is there anything specific they should be looking out for?
Yeah, absolutely. So I would start with the mechanism of the injury. Is it high energy, high speed, velocity? Are you in a car accident? Mm-hmm. And what was the speed of the car accident? That kind of thing. Were you restrained? Were you not? And do you have any pre-existing conditions that are concerning? If you're on a blood thinner and you have a small injury, it could become a bigger problem if you have a bleed that we don't know about from a fracture that we can't see. Other things to consider are, did you fall from a height? Was there a bad twisting injury? Could you walk on weight bear on the knee, hip, ankle, or move your arm or shoulder initially? Maybe not, but shortly after, could you do that? Could you move it? If you really can't do things you're normally supposed to do, or you have severe, relentless pain, then an ER visit is warranted for sure.
So in the patients that aren't so severe, but they know they need to get checked out, what are things they can do at home to help alleviate things, until they can get in and seen by their primary care or with an orthopedic surgeon?
Yeah, a lot of things have changed over time, and some things haven't. One of the things that really hasn't changed is rest, ice, compression. If it's, acute bleed or something like that, elevate. Those initial things. But really to consider also is we often look at the diagnosis. What are diagnoses that are more concerning? Mm-hmm. And then what are the chances you have that diagnosis? So an early injury might lead later to a compartment syndrome. If there's a bleed in a compartment, a muscular compartment where there's a bleed that continues and swelling, and it actually increases pressure and can cause nerve or muscular damage, that's going to be a problem later. Those are more acute. Is there penetrating trauma to a joint? Is there, whether it's laceration or a cut, does it go all the way into a knee or an elbow? Or if it doesn't, cut can be treated depending on the degree or severity. Does it need stitches or sutures, that kind of thing. The other diagnoses to look at are going to be, is it unstable? Is there arterial injury or something? Do I have pulses in my ankle or foot or wrist or hand? Those are things to look at that are kind of obvious to people that the general public can try to assess. And if there's any debate or question, definitely an ER visit.
So you talk about pulses. What are some signs of that patients might know how to check their pulses? There's certain things that extremity would show that they should be aware of.
Well, overall, is it deformed? A deformity is pretty obvious. Mm-hmm. But if it's very swollen, sometimes an ankle dislocation could be missed, or subluxation, which means like half kind of dislocated, moved out of place for basic terms. But if you can't put weight on it, don't. We don't want to test that too early. More emergent things that's very rare also is a knee dislocation. That could be very problematic if there's arterial injury or nerve damage or something in the long run. But in an acute setting, arterial injury, that could be a problem. Other than that, dislocation, sometimes an elbow dislocation can be missed in a strong person, or sometimes if you've got extra weight and you can't quite see the bony prominences, we can miss things in a knee or an elbow. But yeah, it really is pain out of proportion.
Okay.
If you've got pain with passive range of motion, just gentle movement of the toes or fingers, but that's not where you had the injury, you might want to get it checked.
How important are x-rays or other imaging modalities when it gets, to these things? Or is that injury dependent or, joint dependent? Kind of how do you make those decisions?
Well, that's an interesting question because, in my line of work, you might be at a dinner party and someone will say, my shoulder hurts or my knee hurts,
Yeah.
And it's, I'm in an interesting field where it's not too personal to check that out sometimes or to give advice. And I've got to be careful and cautious. The rare chance that someone has a tumor that's undiagnosed and only just started presenting pain, but they had a rotator cuff problem before or surgery before in that shoulder. They sprained a knee and they have knee pain. If they have any type of pain, we like an x-ray at some point. If you're at the dinner party, I'll say, look, I'll give you an idea what it might be, but a thorough exam is more warranted. So keep your pants on, that kind of thing.
Oh, just wait till they ask me to check for hernias. I understand. I understand how that can go sometimes.
That's a little gray there, but definitely you know best.
Yes.
But from my line of work, I would say that in our present field, we want to be sure that there is no pre-existing problem that we're going to miss or write off, and then we go 2 or 3 weeks or months down the road with this persistent pain that worsens that was a tumor that we didn't diagnose, and that's very rare but possible. Initially, your pain, your symptoms are going to present whether or not, if they're very severe and you can't do what you need to do, at least an urgent care visit, because urgent care clinicians and staff are at least trained for the emergent diagnoses more acutely in that setting, and they can help triage.
Okay, so they can get you to the ER or say, hey, you're good to go to primary care.
Absolutely.
All right, perfect. So moving on to kind of the non-urgent injuries, what are the most common causes of those types of injuries? Things that you see that kind of lead to the hip replacement, shoulder replacement, knee replacement. What's that story that you get most often from these patients? Yeah,
it's, I have this pain, whether it's shoulder, knee, hip, and then the next question we ask, well, what did you do differently? What are you conditioned to do? And I try to explain to patients that if your car can only drive 100 miles an hour and you're going to go on a racetrack and race it, and that's the speed, when you push it to 100, you're trying to hit to 105, something's going to happen to your car. It's not conditioned. It's not designed for that speed. So if you are going to lift a certain number of weight, you're a family person and you're a weekend warrior, you might work out here or there, but you really want to do something you did 10 years ago, a lot of running, hiking, play basketball, some aggressive contact sport, anything that you're not conditioned to do more of, what you did differently, you're likely to strain, tear, sprain, have an injury, and it could become a problem later. So how to prevent that? Well, the prevention is, if I'm planning on doing a 5K in June and it's February, then I should probably start to condition myself now. 3 months out, I'll build a little more strength and endurance. Your tendon integrity is different than your muscular integrity. So you could have a tendinitis where, your muscles are able to handle the strength and the load, but your tendon isn't. So that takes more time to develop. So conditioning is a huge preventative measure that helps keep you out of our office in the ER.
When you see patients, are there non-operative measures you can take, or do most people head to the OR, or is there a spectrum where you try something first? What other modalities are there?
Yeah, and that's another great question, because a lot of the patients that present a little late for a problem, which doesn't mean it has to have surgery, but they could have at least had less pain or a step to recovery, is that they're afraid that we're just going to take them to the operating room. We're surgeons when we need to be, but we are doctors before we are surgeons. So it's the question to ask is, well, should I see my doctor for this? It's never a waste of our time. We love to do work. We love to do more relevant work, emergent work. I'd love to be a lifesaver, game changer, but also love to alleviate your concerns or prevent something that didn't need surgery later because you just came to us soon. So don't be afraid to see your clinician to help diagnose something early so that you can at least have a heads up and a first step on treating it non-operatively. And you might have a better outcome and likely will and may avoid surgery in many cases.
So when you have these patients that have these, these acute or the traumatic type injuries that need surgery, fractures, ACL, kind of the knee injuries, what's the downtime for those? How soon are they getting back to work, getting on their feet? Kind of how does that play out for a patient?
A good question. And I think it is dependent on the surgery. So let's say you have a meniscus tear, which is a little tear of cartilage. It's almost like a small ring of cartilage on either side of the round parts of your knee, the condyles that sit on top of the tibia, the shin bone. When you have a little tear, it's almost like we're kind of grooming that in surgery. Rarely do we repair it unless it's in an area where there's a good blood supply. So we just kind of trim it. That's a quicker case. It really depends on the patient's conditioning before and after surgery is a lot easier for them. Some people go back to work within 4 to 5 days. Some people need a week or two to recover, a little pain, swelling, but we don't restrict them. And when it comes to like fractures we have to put back in place, like the knee, the tibia, we're putting hardware in. We need the bone to heal. The hardware just keeps everything in alignment so it doesn't heal incorrectly. And so that requires, depending on someone, if you're smoking, diabetic, immune compromised, all bets are off. It might add twice as long, to recover. But generally speaking, young, healthy adult, male or female, 6 weeks, the bone's pretty rigid. We might start to weight bear on a bad fracture in an ankle, somewhere between 6 and 8 weeks in someone healthy with a good fracture reduction and x-ray signs of healing. Some people might take 3 months before we weight bear if they have other comorbidities or health problems. And so it depends on that. When it comes to ligament tears and reconstruction of an ACL, an anterior cruciate ligament in the knee, which you hear a lot about in sports, that's a longer recovery. It could take 9 months before we let you run or cut. Okay. But the first 10 days are pretty painful, often for the surgery. But somewhere there's a magic number between the first 10 days and the first 2 or 3 weeks where people are just a lot better. They can bend their knee. We let them weight bear on that knee. They can walk on it. They're often in a protective brace depending on the surgeon's practice. We gradually get them through PT to walk and do normal things if you have normal activities. But weight bearing, planting, twisting, pivoting up and down hill, we're looking at a longer, somewhere between 6 and 9 months. And 6 months is aggressive. 9 months is more conservative to do something like that. Rotator cuff repairs in a shoulder, tendon to bone. 3 months, you should be able to elevate your arm and get through it all, but we are guarding and protecting your recovery for, 10 of those 12 weeks at least, if not all 3 months. And then we're not getting you really strong till 3 months or 6 months or 9 months down the road, where we get you stronger and stronger, and then you're back at whatever your level might be, or hopefully near full recovery, and then you have still injury potential because remember, you tore it to begin with. So yeah.
It's never as strong as it once was, unfortunately.
Yeah, and honestly, sometimes the people are not conditioned when they injured it, and they're more conditioned after, and it's your accessory muscles, the rest of your shoulder. There's 17 muscular attachments to the scapula that surround the shoulder. People get better. They do better. Sometimes they are better off, but they could have been, to begin with.
So, Dr. Curdy, when a patient presents to your office, what information are you looking for from them so to help diagnose, what's pertinent, what's not pertinent? How do they help you help them the most?
The answer to that question applies to just about every medical specialty and subspecialty. It's very relevant in orthopedics. If you had people come in and they sprained their ankle, and, I'm in my 40s, so they're that age, but they'll mention that, I sprained this ankle in my 20s a couple times, and this is my bad ankle. But was it bad in your 30s? No, I was great. I mean, we fully recovered, and there may be some aftermath or residual post-traumatic arthritis sometimes in some cases, but usually not. And so this is a new injury. Even though you've had that, it's a new injury in the same joint years later. So being able to differentiate, this never got better. I have never improved from my 20s. I've always had pain and instability, and now it's worse, or now I have a new injury on top of that. That helps us. But really, the storyline, one thing I always try to promote to my patients is we have all the room in the world in our hearts for all our patients. I don't have the capacity to remember all the details of every single case, and that's why we have charting and electronic medical records and scribing and all that. So the less irrelevant details would be beneficial. We'll hear it. We have compassion. We understand that there's a person behind the story. It's not just the injury. Not to distract us from by the way, I also have a blood clot in that leg. I didn't tell you about, because you're telling me about the actual storyline of what happened with the injury. So things that aren't distracting. So we always want to know, when did it start? Has it really been a problem forever? Is it a newer problem? What is the severity of the pain? What have you done? What makes it better or worse again? And trying to keep it where, we know what answers we're looking for, and allowing us to ask the right questions, and then trying to answer them more specifically would be more efficient. We'll find a way to help you, even if you're not efficient, and we'll hear your story, and we'll share all the love we can. But yeah, definitely don't want to avoid missing great detail and then providing other details that are distracting.
Perfect. Dr. Curdy, thank you very much for joining us again. You're always a pleasure to have. I'm sure we'll find more topics to get you back here in the future. Thank you for tuning in to the Memorial Healthcare Podcast. This is Dr. Flermone. Please feel free to rate us on wherever you listen to your podcast. Until next time, stay safe and stay healthy.